Okay, let's talk about our patient today. Our patient today is a dentist. Young lady, a preeminent lecturer, a dental hygienist from Bulgaria, Buffalo, New York, Atlanta, Oklahoma, Vancouver, Canada, Boston, Kansas City, San Francisco, Montreal, Munich, Germany, London, and Santa Maria, California. And we're going to place 14 Lumineers, 8 Lumineers, 10 Lumineers, 6 Lumineers, 10, 2, 8, 8, 10, 10, 8, 10, 8 Lumineers today on our patient. And now we're not treating teeth anymore. We're treating smiles. Isn't that beautiful? So let's look at the transformation from where we started and where we are. Our patient today is an example of that. I'd like to welcome you all to a webcast placement on a patient that would like to look better and doesn't want to have any shots and doesn't want to have his teeth ground down. Been doing these for over 20 years, and I've never had to give a patient a shot. I've limited my contouring to that which did not hurt the patient. Then I tell my technician, this is all I want to take off. You make it look good. Whereas traditionally, the technician tells us, take off as much as you can, and the more you can take off, the better job I can do. Your two most reliable surfaces that you can bond to are enamel and porcelain. There's absolutely no difference in bonding to porcelain than there is in bonding to enamel, except for surface preparation and giving a silanated bond a little extra time to mature before you put pressure on it to open your contacts. Now, before we begin, you should have a knowledgeable assistant. My assistant with me today has been with me for over 20 years, and she knows what I need before I ask for it, and she's got everything prepared on this if we can get a view of how she's got the tray set up. All right, now before we start, Lisa has treated those pieces of porcelain with porcelain conditioner and Serenade Prime. We had the patient in yesterday, and we checked out for shade and made sure these were going to work okay. We've got a little bit of an issue here. Now, if you take a look at his teeth, that's good. This is what we're going to have to look out for, is occlusion, and they've already compensated for that a little bit. All right, let's get going here, because we got a patient that's a knowledgeable patient, has flown several thousand miles to get this done, to teach it, and to experience it. And so there are some tips that I have to give you now to tell you that make it simple. One is I use 4-power magnification. I work without anesthetic, and that's why I want 4 power, so I can be more discriminating when I get into sensitive areas. The other thing you want to have is a Sapphire Light. I don't know if anybody has a Sapphire Light. If you do, raise your hands real high so you can tell everybody else. But people that have a Sapphire Light, it's like, as Gordon Christensen said, if you don't have a Sapphire Light, it's like working with a slow-speed handpiece instead of a high-speed air rotor or electrical handpiece today. We recommend Lumineers impression material. There's a lot of good impression materials out there, but a couple of tips. Before you send in an impression, pour it before you let your patient go home. Take a look and make sure you're satisfied with the gingival margins. So that's an important thing to do. And the other thing you want to do is not take it out too soon, because if you get some veneers that fit the model and don't fit the teeth, and you decide that Ultrabond can't even make up that difference, then what you want to do is remember that you probably had distortion when you removed it, because a little distortion looks no different than one that's a perfect impression. So leave them in for an extra 30 seconds. Lisa has polished his teeth with the Lumineers polishing paste. We use that because it has an enzyme in there to get rid of the plaque on the surface. So when we start surface treatment, we'll get the best bondable surface. And with that, we'll get started. And the next thing we're going to do is place some paint-on dental dam on the lingual side. The reason for that is that it will prevent the Ultrabond and the tenure from bonding to all the places that we put the paint-on dental dam. Now, the place you want to be careful is where you have diastemas, because if you put the paint-on dental dam on that, and then you try to put the veneer in, it may not get seated all the way. Best way to protect your eyes is close them. Close your eyes. Give them a 3-second blast with a 9mm tip. Close your eyes. And I just cure this to the rubbery stage. There you can see they paint on dental dam. Just be very careful that you don't let it go from the lingual to the labial, and then that'll prevent your Lumineers from seeding. I'm going to use etch and seal on the enamel, and it contains aluminum oxalate. And the purpose of the aluminum oxalate is when you're doing your regular operative procedures, if you're getting on open dentin, the aluminum oxalate helps seal it and prevent sensitivity. And I like the medium viscosity, so I can push it around instead of having it run all over the patient's mouth. We're applying 2 solutions on the enamel, etch and seal, and then tenure A and B. Tenure A and B was developed by a scientist by the name of Dr. Ray Bowen. Now Lisa is going to give me the upper left central. Okay, and we tried these on, and we tried them for shade. We're going to put the shade on here. I want to show you something. Why you need the tri-in paste. The Ultrabond tri-in paste is the same as Ultrabond, but it doesn't have any activator in it. So we just put a little bit on here like that. It's got the tri-in paste. And remember now, both of these Lumineers are the same shade. So why do they look different? Well, here's a little tip. When light goes through a medium, if it doesn't exceed what they call a critical angle, it continues to go forward. When it got to the etched surface of that left central, there's air there. It exceeded the critical angle, so you're getting back a reflection of the etched porcelain. That's what you would think would be the shade. But when you put the tri-in paste in, you can see it's a different shade. So we always give patients the option between 2 shades, 2 light and 2 dark. And because when you're doing 8, and I always recommend you do 8, I always try to avoid doing 2 or 3. Sometimes you have to do what you have to do, but if you really want to get a great smile, you want to do 8. Which shade do you like better, the one on the right or the one on the left? You want the one on the right, okay? And I don't spend a lot of time looking at all of them in, because once you and your patient start looking at what's wrong, then nothing ever looks good again. What I'm using here now is something called Tenure S. Tenure S is what Lisa's going to use to remove the Ultrabond tri-in paste from the Lumineer. And you never want to put Tenure S on when you do the tri-in paste, because if she doesn't get all the tri-in paste out, and there's some in there, then the Tenure S will cause it to polymerize. So it's a backup system in case you don't get enough light to the area. Left central. And I want to see excess oozing out everywhere. And this is a real critical stage right here. We're using something that we're just beginning to work with, and it's a suction device to carry the Lumineer to the tooth. Take the brush, and I want to get that done fairly soon so these don't float all over. Give me the 2mm tip for 1 second. Close your eyes. Close your eyes. Close your eyes. And close your eyes. Now I'm going to take the 9mm tip for 5 seconds on each tooth. Close your eyes. Close your eyes. And here, let me give you a quick look and let you see what it looks like on the lingual. Now, we're off the runway and we got wheels up. So all we have to do from here on in is finish. So the next thing we'll do is start taking the Sure 349 instrument. And you see we're going to use that a lot. And I'm just peeling off this paint on dental dam like you would after you were bleaching a patient. Let's take a look at what that looks like on the lingual side now. Look how sharp that gingival tissue is. So now we're just going to play takeaway. And I'll start out with the football-shaped diamond, American football. You always need a copious amount of water. And I'm blending the Ultra Bond and the porcelain together. Now take a long, narrow diamond. And it's very important to get all the Ultra Bond out before you try to open the contacts. Because if you run into resistance, it's usually because the Ultra Bond is preventing it from going through. What we're doing now is just taking off the set Ultra Bond, and everybody in the audience is saying, oh, that isn't clean and neat. And you don't see any bleeding going on in here, do you? That's because I've got 4 power. And we want to get all of this Ultra Bond out of the interproximals and around the margins. And we're staying away from the glazed surface. Now I'm back to my Sure 349. See that? And what I'm doing now is just pretending like my Sure 349 is a scaling instrument. Now the reason you want a Sure 349 instrument is you'll never scratch the glazed porcelain. So usually what I do is I do about 90% of the finishing on the placement visit. And we have the patient back in about a week, and I do everything that I missed on the placement visit. Now we'll take a quick peek here, and we'll compare what the patient looks like now compared to what the patient looked like 50 minutes ago. Now let's take a look like how he started. Now let's take a look like how he is. Okay. So now what we have left to do is get rid of the shoulders. Let's take a look at the lingual side. Makes it open wide. So now we can do all the contouring and changing we want to. And the first thing we're going to do is I would like to get that needle nose diamond. I'm going to go around these gingival margins, and I'm going to blend them with the tooth. And I'm going to work on the porcelain. See, this is where it takes a little skill, but it saves the patient a lot of tooth structure to do a Lumineer. We're in the habit of destroying a lot of tooth structure for the benefit of the technician. So I'm probably taking 20 minutes to finish, but I took nothing to prep. Now we're going to look at something here real tricky. I want to draw your attention to this occlusion. This occlusion. See this occlusion here? Okay. This is what I have to look out for so he doesn't break these things off. You have to be able to create a harmonious envelope of excursion. If you can't do that, you're going to have chips and breaks and failures and all kinds of things. Now let's see what kind of marks we got. Open. See this mark right here? I have to get rid of that or it's going to break the opposing tooth, the Lumineer. Gently put your teeth together. Gently grind them around, sideways, forward and back. His bite looks pretty good. He's biting on the lingual cusp of the bicuspid. Lingual cusp. Can you see that? Okay. Okay, so now we're going to see if we can open these contacts. Now, I do all the easy ones on the placement visit. And I start going through there. I'm using a thing called a seri saw. And I just use firm pressure, but not too much. And if I run into too much resistance, then I stop and I rock. See how I'm rocking here? Now I'm through that contact. And I don't open them all on the placement visit. Usually when I get back to the bicuspids, they're a little more difficult to open. Now the reason I don't like to do all my finishing on this visit, and I could, is because a patient's been sitting in the chair here for a little while. Patient's been sitting in the chair for an hour. And then you can say, well, that's not very long. That's because you know how long it used to be when you did preps. So if I can get a patient out of my chair within an hour to an hour and a half and get this much transformation, I can tell you they are amazed, they're grateful, they're appreciative that I didn't force them to go on the torture rack to have to look better. I'm using a seri sander now, where I went through these contacts with the seri saw. Seri sander is a diamond impregnated thin steel. Orthodontists use it to get rid of the rough stuff around the contacts. And I'm using a fair amount of force. Now let's take a look at it. What do you think? You want to take those home?
Love them.
Huh? You love them?
Well, hope you have a nice convention. If you get a chance to come out our way, we'd love to see you. And thanks for being such an attentive audience.
My name is Dr. Henry Young, and I live in Nashville, Tennessee, teach at Meharry Medical College. I'm the director of the General Practice Residency program there. And for years, I've always considered having my diastemas, or my spaces in between my teeth, closed. But I didn't really want tooth structure removed. So I attended my first course in Louisville, Lumineers course, and then I came out to Santa Maria to the placement course, at which time I was sold and decided to have those placed on myself. With the ability to offer a treatment modality such as Lumineers, where no anesthesia is involved, no pain, I am definitely sure that's going to increase the request of my patient to change their smile. Lumineers have made a difference already in my self-esteem. And I'm sure as I go out and I talk more, smile more, I want to be conscious of how large I smile, because sometimes I'm self-conscious about my smile. But now I don't have to be self-conscious anymore. Everyone who does not like their smile, they need to have Lumineers.